Well, good morning. I guess we can get started. So thank you for joining us today. I'm Mark Periscindola, Branch Chief for the Research and Training Branch at the NCI Center for Global Health. This year, we're celebrating two anniversaries, 50 years since the 1971 National Cancer Act and 10 years since the creation of the NCI Center for Global Health. The 1971 Act strengthened the National Cancer Institute, established a comprehensive national program against cancer, and reinforced the importance of cancer prevention and control to reduce the cancer burden. The Act also highlighted the need for international exchange and research collaboration. And then 10 years ago, the Center for Global Health was created at NCI to advance global cancer research and coordinate NCI engagement in global cancer control. So to mark these anniversaries, we've launched the NCI Global Cancer Research and Control Seminar Series this year. So the seminar series features talks by researchers and cancer control experts working in global oncology, providing opportunities for discussion and collaboration around impactful and innovative work on cancer morbidity and mortality worldwide. So today, I'm delighted to introduce our speakers, Dr. Donna Shelley and Dr. Nguyen, who will discuss their NCI-funded work in tobacco cessation in Vietnam. So Dr. Shelley is Professor of Public Health Policy and Management, Vice Chair for Research, and Director of the Global Center for Implementation Science in the Department of Public Health Policy and Management at New York University School of Global Public Health. She's also co-lead of the Epidemiology and Cancer program for the NYU Perlmutter Cancer Center. And Dr. Shelley has built a program of translational, population-based, and policy-relevant research that aims to optimize dissemination, implementation, and scale-up of tobacco use treatment in healthcare delivery systems in the US and Viet Nam. And Dr. Nguyen is Director of the Institute of Social Medicine Studies in Hanoi, Vietnam, where he oversees the Institute's Survey Center, Training Center, Center for Health and Nutrition, and administrative functions. He has served as principal investigator or co-investigator for over 30 large-scale quantitative and qualitative studies in HIV/AIDS, reproductive health, non-communicable diseases, and behavior change, and has substantial experience in conducting large-scale surveys and data analysis with complex data sets. So as a final note, before we get started, I want to note that today's presentation is being recorded and it will be available on our website at cancer.gov/global health. You can also find more information about future presentations on our site and by following us on Twitter at NCI Global Health. So a warm welcome to Dr. Shelley and Nguyen, and we look forward to your presentation.
Okay. Good morning. Can you hear me, Mark?
Yes, we can hear you.
Okay, great. Good morning, everybody, and good evening to my colleague, Dr. Nam, who's in Hanoi right now. Thank you so much to NCI for your funding over the last decade and also for giving this opportunity to present our research. So this is just an overview of the talk. We wanted to start by introducing Framework Convention on Tobacco Control because it really informs all of the research we've been doing. And some of you may not be as familiar with global tobacco control. And then we'll present these three studies more in depth with the first one, and then just a single slide on the last one to show the trajectory of the work, and then share some implications of the research and recommended next steps. So the Framework Convention on Tobacco Control was launched in 2003 and signed by over 168 countries. It was the first time the WHO invoked the authority to establish a treaty. In 2008, actually, WHO sort of simplified the treaty by outlining the Empower program, which is basically priority demand reduction measures to reduce tobacco use. I highlighted the Offer Help to Quit Tobacco Use because that is the Empower domain that all of our work is really focused on. And the countries that signed on to the framework are actually required to make evidence-based tobacco use treatment available to all tobacco users. So how are we doing? The Empower report in 2019 shows persistent disparities across countries by income, with low-income countries really lacking in availability of nicotine replacement therapy, other cessation services which are considered best practices by the WHO, including having a national quit line and coverage for smoking cessation services. In an attempt, I think, to change that, the WHO released in 2010 these guidelines. And I bolded the components that are areas in which we are specifically, our research is specifically addressing. Despite the guidelines, again, this remains a challenge and has lagged. Article 14 has really lagged behind many of the other framework convention articles. I'm sorry, my mover isn't working, but okay. So what are the barriers to implementation? Why is this such a challenging issue? And we analyzed an open-ended question on a survey that was conducted in 2015 among 127 countries, people who worked in the Ministry of Health on this issue or affiliated somehow with tobacco control work. And the number one barrier was identified as a lack of political will or priority. In some ways, it's still related to tobacco industry interference. But the bottom line is that without this being a political priority, the funding doesn't flow, the infrastructure doesn't improve, providers aren't training, et cetera. And so once, a framework like this helps us sort of think about where are the pressure points that we need to work on to change this and increase access in not only high-income countries, but in low and middle-income countries as well. So, what's the approach to overcoming barriers? Well, as an implementation scientist, I would say implementation research. And of course, NCI has been all in on this a concept of how, studying and funding research on how do we get evidence-based interventions like tobacco use treatment and tobacco control policies into public health practice and policy. And so, the first two bullets define what implementation research is. The PAR is something that NIH, including NCI, has sponsored for many years now. And it talks about really the study of implementation strategies to increase adoption of evidence-based interventions. And the obvious question is, what is a strategy? And this is something that trips up a lot of people not familiar with this field. The strategies are the how-to of implementation research. Basically, they're the interventions that we use and test to improve uptake of the evidence-based intervention or the thing that we're trying to get into practice and policy. So just one more concept about implementation science that I wanted to share before we get into our study, because we are presenting, the first study is a type 3 hybrid design. And what's a hybrid design? Well, the hybrid design really acknowledges that even after an effectiveness study, we don't have the information yet that we need to get to that next level of implementation. And so type 1s are primarily asking the question, is an intervention effective in this context, in this particular context, but also trying to understand and gathering data around the context of implementation. Type 2 looks at prioritize both testing the intervention effectiveness, but also starting to think about the feasibility of potential impact of implementation strategies. And type 3 is saying, okay, we have the evidence, now we need to implement and test and compare different implementation strategies to increase uptake of that evidence into practice. And the secondary outcome in this case is a clinical outcome, in this case, smoking cessation. I just point out that as you move to the right, the importance of qualitative data really increases, and all of our work includes the qualitative, mixed methods approach. So this is the trajectory of our research, and again, thanks to NCI for giving this opportunity to ask and answer questions along the way over the last decade that are important, not only to all of us who care about tobacco control, but to policymakers. And having the opportunity to continue to work, in a longitudinal fashion allows you to start to ask different questions as the context changes. So in the first study, we were asking, what strategies, and this is a hybrid type 3, what can we use to increase implementation of tobacco dependence treatment At the time, there was no quit line. And so our referral system was to refer patients to a trained community health worker. Fast forward, the second study, there was a quit line at the time, and the policymakers, the Ministry of Health, was considering adopting a text message intervention, which the WHO is promoting now, and including these two population-based approaches, both the quit lines, national quit lines globally, but also text message programs. However, those programs have been developed and shown effective in high-income countries, require major adaptations, not just language translation, but to adapt to the sociocultural context of, in this case, Vietnamese smokers. And finally, having the chance to expand our work to another setting, the first study to another setting, and doing a hybrid type 2 study, comparing the effectiveness of 3 interventions among people living with HIV, and at the same time studying the feasibility of strategies for increasing implementation if we find one of those particular interventions is particularly cost effective. And I just want to emphasize again that being able, the work we do squarely focuses on working and collaborating with policymakers, and Dr. Nam has really made that possible with his close collaboration with the Ministry of Health and other organizations in Vietnam to really stay aligned with what are the questions that they are trying to answer to move implementation of the Framework Convention forward. So this is Vietnam, and Vietnam was an early adopter of the FCTC. They ratified, I think, in 2004. They've implemented many of the articles, smoke-free air policies, counter-advertising, recently a tax to fund a tobacco fund. In the first study I'm going to present, we worked at the commune health center level with village health workers who both function as a group of workers who are implementing in the community the priority public health programs from the Ministry of Health, but also serve as, I call them clinician extenders, essentially. So they were sort of the ideal group to engage in the design that we came up with. Again, this is a type 3, and I just want to reiterate this before I show you a different slide on the design. The question was, what implementation strategies would work better to facilitate implementation of treatment? And the secondary was the clinical outcome. Are clinical outcomes similar in this context as compared with the primary context? And I think, what became very clear when we presented this at the launch meeting, and the Ministry of Health knew what we were doing, was very interested and excited about it. But their primary question was flipped. And I really want to acknowledge that right up front, that they were really, yes, they wanted to see how we could actually get these evidence-based interventions implemented, but they were really concerned also about showing that, in fact, something that was shown effective in a high-income country could be transferred and achieve comparable outcomes. Were community health worker and providers at commune health centers able to provide effective treatment? And just to say, I don't think I've even mentioned what evidence-based treatment is. And the guidelines suggest that screening all patients for tobacco use, providing brief advice, assessing readiness, assisting either with pharmacotherapy and more additional counseling through either a referral to an outside source is an evidence-based approach. And brief counseling does increase quit rates, but but intensive counseling can further increase cessation rates. And in combination with pharmacotherapy like nicotine replacement therapy is really the best practice in terms of achieving better cessation outcomes. So our conceptual framework was the consolidated framework for implementation research. And we hypothesized that implementation strategies would act at the individual level, improving attitudes, norms, and increasing self-efficacy. But at the institutional or clinic level, we would also be changing the climate for treatment, organizational priority, and compatibility of treatment. That would increase in Arm 2, the sites that had the ability to delegate intensive counseling to a village health worker would actually be more likely to adopt the 4 A's. We looked at these outcomes both quantitatively and qualitatively. Oh, it's finally working. So like many type 3 or implementation studies, it was a multi-phase cluster randomized trial. When you are transferring, again, evidence produced in one context to another, it's necessary to start with a formative assessment to do the adaptation that was necessary. And there was a lot of adaptation needed. We were working in sites without electronic health records, with no prior training. There were no materials available. And so we did a lot of interviews with providers, policymakers, village health workers. We did surveys, and we used that data to adapt the manual, all the system changes and the training. And then we randomized 26 sites into the training and toolkit, which I'll show you pictures of, which were the system changes versus that plus the referral system. And that was the RCT of 26 sites. And we also looked at process measures of fidelity during that time, and then ended with additional qualitative and quantitative data collection to understand what happened. What worked, what didn't work, what needs to continue to be adapted further, and what is the potential for sustainability. This table shows you what that analysis assessment looked like. And just want to focus on, you're probably wondering, well, how did you actually measure adoption of the guidelines? And we did that through a method that we've used in the US that seems to be the most valid way of doing this assessment, which is we do patient exit interviews pre and then post. And these are cross-sectional interviews. We're not following a longitudinal sample of patients. We look at them, we ask if they smoke, we intercept them at their patient visit. If they do, if they're willing to fill out an interview, when they're done with their visit, we do those patient exit interviews asking about the 4As and referral and a couple of other questions, but it's pretty brief. And we do that pre and post. We also, though, did ask providers to complete pre-post surveys that also asked them about their own behavior. And we're glad we did that because we're also follow up to look at sustainability at 12 months of provider adoption of the 4As plus R. Cessation rates were assessed with carbon monoxide validation at 6 months. We looked at below the darker line are the implementation measures of fidelity. We also assessed quantitatively and qualitatively the consolidated framework for implementation research constructs at the outer setting. What are the sort of policy environment, intervention characteristics? What are the characteristics of the intervention itself, screening, providing brief advice, and the implementation strategies, looking at priority, fit, and the theory, plan, behavior constructs of norms, self-efficacy, and attitudes. And we also did a cost analysis. Dr. Nguyen led that at the Hanoi University of Public Health, which was actually extremely interesting because this was very inexpensive if you just look at the intervention itself. Obviously, the cost of developing all the materials and the implementation part, increased the cost per smoker engaged in treatment, but generally the cost was very low. So what were the strategies? So you can see here that we really had a lot of adaptation to do. Again, all they had at the time was a log. And again, the context is changing. And so I think one of the things, you think about when you do a study like this is, sort of what happens when they get electronic health records and, sort of we want to go in there now and maybe not do a randomized controlled trial, but actually look at sort of the further adaptations that need to be made. But the look at the flip chart in the middle, you'll see that is our version of a clinical decision support tool. And that the providers really like that. And also having the patient brochures, which are to the right, as a point of service support system for them to help them remember. And remember, they had no previous training to remember sort of how to talk to a patient, which questions to ask. The posters were our version of a reminder system. They were in all over the settings, asking about, it says ask, advise, assess, assist, and in the referral arm 2 sites, it said refer. We also did several day training. Sorry, I'm just having trouble with my clicker. Okay. The training included a lot of role playing, and we got a lot of positive feedback from providers that this kind of skills building approach was not something that they had typically received and really helped them retain the information. And so This was a several-day training, both of the providers, healthcare workers in the sites, and then we did an additional couple of days for the village health workers to learn how to use the counseling manual. Oh, this is just another picture of the two community health workers on the left role playing. So what did we find? We found a remarkable increase in adherence to the guidelines. And there was no difference between arms. So our hypothesis was not proven, but we're sort of not sad about that because we got a remarkable response to the changes we made. And I think in some ways, you could say that training alone was probably a large driver. However, sustainability required, I think, the system changes, as we know, are important to sustain this kind of change. So again, a remarkable increase. Interestingly, the Arm 2 sites were slightly less likely to assist, and probably because they had this referral resource. But again, not different across arms. Why was that the case? Well, if you look at this slide, you see what was hypothesized as mediators. And we found that, in fact, this is, by the way, we combined Arm 1 and 2 because there was no difference, again, probably explaining why Arm 1 and 2 did not differ in the main outcome. There was no difference in changes in reported attitudes, norms, and self-efficacy. And so we combined the data. At baseline, 6 months, 12 months, you see increases across the board. However, they started with positive attitudes around smoking, providing treatment, and also felt that patients expected this from them. So what the main effect was that the intervention the strategies and the intervention seemed to really enhance self-efficacy. And self-efficacy is been shown to be the most important driver actually of behavior change, and in this case, provider behavior change. Let me just add that there were 3 other questions that show that related to climate, priority, and compatibility. I don't have time to go through each of those, but basically reports agreement with tobacco dependence treatment as a high priority in this health center increased from 49% to 79%. Similarly, with helping patients quit smoking fits well into my practice, and healthcare providers get the support they need. Both also increased from around 60% to over 80%, again, across both arms. There were good results across type of tobacco use, but we do see a significant difference between the water pipe users in terms of receiving treatment from providers. We did include a module on treatment of water pipe users, but again, more work needs to be done in this area. But comforting to see that the providers were providing assistance across the board. And this is the sustainability data. Remember, this is not the PEI data, patient exit interviews. This is based on provider surveys, pre and post, up to the 24-month. And you see a drop off. What I found really interesting is providers in the US tend to overstate what they do compared to patient exit interviews. And here they actually understated what they were doing. But I think, again, it speaks to this issue of needing to continue to monitor and evaluate these interventions to make sure that we're sustaining outcomes. And then the last slide on outcomes is the cessation outcome. And I just want to clarify what this is from. This is actually based on a quasi-experimental sub-study we developed when, in fact, the Ministry of Health was very clear. They wanted to know, not just at the population-based level, did providers improve treatment, but was the CHW more effective than the provider behavior? So this is quasi-experimental because during the intervention period, we recruited patients who had in Arms 1 and Arms 2. Arm 2, those who received village health worker intervention versus plus provider behavior, provider advice to quit, versus Arm 1 just receiving provider advice to quit. And what you see is carbon monoxide confirmed 6-month abstinence in over 1,000 patients. And these are remarkable findings in part because there was no nicotine replacement therapy here. I think the other thing I want to point out is the 10.5% rate of quitting for just brief advice is comparable to what we see in the literature in general that was generated again from high income countries. And so providers can be as effective as the literature suggests they can be. And that we know, we confirm that adding additional counseling sessions and more intensive counseling can actually double quit rates. And so this was the answer to the question that the Ministry of Health is really very interested in understanding, as well as knowing whether the strategies we were testing were effective. I don't have time to really go through this. I'm gonna, because I don't want to dig into Dr. Annan's time. So, you know, some of the barriers were, you know, they're busy. They have a lot of programs to do. You know, other programs actually that are seen as priorities from the Ministry of Health get incentives. The Ministry of Health needs to start to provide resources for us if this is going to be one of our priority programs. And then sustainability, though, there were a lot of really great comments from the providers saying, you know, even if we don't get the resources, you know, we're still committed to doing this. This is patient demand is high, which we feel may actually influence the public health folks to actually provide funding. And then in terms of the strategies, the village health workers felt that this was a bigger burden for them, and they suggested switching from a one-on-one approach to actually using their community engagement approach, you know, doing group programs or changing just the protocol around how they're delivering this to make it fit in a more feasible way into what they're already doing. So the recommendations they had to sustain were aligning with public health priorities, obviously ongoing engagement with the Ministry of Health and sharing this data, incentivizing the providers and the village health workers. The providers actually were really interested in monitoring and feedback. They don't have the systems at this point internally to do that kind of work, but they were eager to see how they were doing. And then one of the key suggestions they had, which was to integrate with other chronic disease programs. So they were doing something on lung health, and it makes no sense. I really believe that this is not sustainable unless tobacco control doesn't remain sort of this orphan public health program, but rather gets integrated into other NCD initiatives. So we showed that we could adapt with fidelity and intervention in a low-income country setting, demonstrated a model of care that sort of applies a task shifting approach that was effective. Early ongoing engagement with the Ministry of Health is critical for responding to data needs and sustainability. And we also have work to do to respond to changing contexts. The biggest gap we have really is a need to adapt validated measures in these settings. We really lack validated measures and more research to improve water pipe use. So let me hand it over to Dr. Nguyen. Thank you.
Good morning, everyone. Let me continue with the second study. From 2017 to 2019, with funding from NCI and NIH, we conducted a study to develop and test the feasibility, acceptability, and the effect of SMS cessation intervention among smokers in Vietnam. And actually, this study was the first one in Vietnam to test, to develop and test SMS cessation intervention. So the study included 3 aims. We call steps. With aim 1, we develop and adapt messages. We based on the smoke-free text and text to quit, and we develop SMS library. And we test that with using focus group discussion with 7 groups with 58 smokers to get their opinions and assessment on the SMS text. And then we revise and finalize the library, the SMS library. Then we aim 2, we test the feasibility and acceptability of the SMS library. We employ a single arm pretest with 40 male smokers. And during the intervention, 40 male smokers receive 6 weeks of SMS text, 1 or 2 weeks pre-quit date, and 4 weeks post-quit date. And we conducted the baseline survey and 6-week follow-up survey and post-intervention. We conduct in-depth interview with 15 male smoker. And then based on the findings from AIM2, we modify and finalize the SMS library. To go to AIM3, we assess the preliminary effectiveness with the design of 2-arm RCT with a sample size of 150 control and 50 intervention. For the intervention, 50 male smoker receive 6 weeks by directional SMS program. And for the control group, they just receive 1 text per week assessing smoking status. And we also conducted baseline survey and follow-up survey at 6 and 3 months follow-up, 3 months post-intervention. And also we also conducted some in-depth interviews with at 6 weeks with 16 smokers participants. The outcome included the feasibility, acceptability, engagement, and the main outcome is a CO validated quit rate at 6 weeks and 3 months. Next slide, please. So the qualitative findings help us to modify and the SMS library. With M1 and M2 qualitative data, we inform us to modify the text to be culturally relevant. And for example, we emphasize on family support, refusal strategy, preference for negative frame messages, and more messages about harm of smoking. And the participants also success some modification that they prefer more negative frame message, harm of smoking, more tips message to help them to deal with craving. And they also wanted to extend the program longer. So the slide shows some quotation, what they share with us. Next slide, please. Here's a SMS text program. We have 188 SMS text in total, and 2 or 3 texts per day for the pre-quit date, 1 to 14 days, and then quit date, and then for post-quit date we have 20 days. So 2 or 3 texts per day the participant would receive. Next slide. So let's talk about the results. The engagement is very high and quite high, and you can see that 36 they stay with the program about 36 in both intervention and control, and frequency of reading message also very high, about 80% participant in intervention, also in control group, always or usually read the messages. And the satisfaction also high across both arms, intervention and control. However, there was some evidence of less satisfaction among control group. For example, they was more likely to report very unsatisfied overall or too few messages compared with the intervention arm. And the results also show short-term efficacy, and the CO confirmed quit rate among intervention it was higher than that among control group at 6 weeks follow-up and also 3 months follow-up. And you can see 20% among the intervention group quit compared with only 2% among control group at 6 week follow-up, and at 3 month follow-ups 12% among intervention quit compared with 6% among control quit And apart from the among those who did not quit, the result also show they reduce tobacco use. And you can see that the mean number of cigarettes and water pipe smoked per day at baseline survey, 6-week follow-up and 3-month follow-ups in the intervention group and also the control groups reduce. For example, from 14 and 15 reduced to 7 and 4 at 6 weeks, and to 6 and 5 cigarette per day at 3 months follow-up. And also in control group, we saw the same reduction. So we think that we think that this the study, the first study is in Vietnam to develop and to test the SMS sexation intervention, and it's really feasible. So this program really feasible, acceptable, and the results show positive effectiveness to increase short-term quit rates among Vietnamese smokers. And we also see that needs for adapting SMS intervention to align with cultural factors that influence tobacco use in Vietnam and also in low and middle income country. And we see that we need some additional research to continue to explore how message and other characteristics of SMS intervention can be more effective design to motivate long-term abstinence. And actually, as Dr. Shelley mentioned that now the MOH is developing the national SMS cessation program, program. So they based on the library we developed from this study. So we hope that that large-scale expansion will be done shortly. Yeah.
Okay.
So, yeah.
Thank you. Thanks. I'm gonna again, please put your questions in the chat. I'm sure some of these are generating, questions. We can't give you all the details in a short time, but
Yeah.
I did want to just give you one slide on the third study, because again, I think the trajectory of the work is important to see, in that NCI has put out a couple of RFAs and program announcements around testing and scaling or implementing tobacco use treatment in HIV for HIV patients. And we received this, we're 1 year into this project. This is a type 2, though, where we're studying. This is a study where we're randomizing at the individual level patients into one of 3 different intervention arms to study whether providers brief advice to quit plus a referral to the quit line, again, leveraging an existing resource at the national level, which is sustainable, is an important pragmatic question that's relevant to policymakers. And so we wanted to include that arm. There is, as you see, not a control arm here, but we're looking at that arm. Arm 2 is AA plus on-site multi-session counseling delivered by a trained nurse, and which builds on what we did in the first study, which is tailored to HIV patients, and arm 3, which adds a nicotine patch. And on review of this grant, we got dinged a couple of times by clearly tobacco researchers who wanted to know, why aren't we giving everybody nicotine replacement therapy? And the reason is this is an important policy question to answer in Vietnam. Policymakers want to know, am I getting more bang for my buck? And so, the question is, and we have even more robust cost effectiveness analysis actually for this study to answer the question of, is it cost effective to add nicotine patch to counseling, to brief advice and additional more intensive counseling. The primary outcome, because this is a type 2, is the effectiveness outcome, but we do have the secondary outcome of looking at whether providers are adopting tobacco dependence treatment And we are using some implementation strategies that we used in the first study, again, adapted for this context, to get providers to deliver the ask and advise with fidelity and do the referral. So you see components of the first study in this study, but again, adapted for this population, adapted into a primarily effectiveness study because the data for treatment is not really comparable for HIV positive patients. And so more to come as we start to launch our RCT of this study. So what's the implications? More D&I research. We have a lot more questions to ask and answer. About barriers of facilitators, particularly to policy adoption. What are the dissemination strategies needed to enhance adoption of tobacco control policies? How do we strengthen systems to achieve health equity, and on and on and on. And just did additional research, just sort of efficacy and effectiveness studies on treatment for different types of tobacco use. And certainly ends policy is going to be increasingly a growing issue in this environment. I just wanted to mention one thing about achieving equity. And I think one of the reasons why I was so excited about the HIV clinic study was that I think it's really important. If we're going to have equity, we need equity in terms of entry to healthcare systems. So everywhere a patient enters a healthcare system, they should be able to receive brief advice and be screened for tobacco use and referred to, whether it's quitline or other programs for treatment. And here's some sort of other issues around essential medication coverage additional need to explore treatment for non-cigarette tobacco use, which may be actually higher among lower income populations because they're not taxed in the same way cigarettes are. And finally, future directions. My wish list is for NCI to expand the implementation science centers and cancer control to the global context. And that wasn't available with the first round of funding of the 7 centers, which are doing remarkable work. And I'd love to see this expand to opportunities globally. There's a lot of interest in growing capacity among our colleagues in low income countries and translating training into multiple language and developing networks where we can facilitate interactions between the decision makers, implementers, and researchers. So we continue to make sure that our research is answering the questions that policymakers and implementers need to adopt evidence-based interventions. Thanks to our teams across these different projects. And I'll end with a picture of one of my favorite places, or the most beautiful places in Vietnam, Ha Long Bay, that Nam and his family took me to on one of my visits. Thanks very much.
Great, thank you. Thank you both, Drs. Shelley and Nguyen. We have some time for questions, so I'll just remind folks, feel free to put questions in the chat and we'll be tracking those. I see a couple of questions here already. So first question is, can you talk about plans for scaling up to adopt or replicate the intervention across diverse settings? And I guess one thing that comes to mind here is, obviously this adaptation and strategy development was occurring within a very particular context within Vietnam. So I guess I'd also be interested to hear, how much of that sort of adaptation process is specific to Vietnam, and how much can the adaptation and strategies potentially be sort of replicated in other LMIC settings?
Should I start now? I can start with I think this question of local versus adaptation and versus generalizability is a real challenge. But I think there were aspects of this that sort of training was based, frankly, on really standard curriculums and competencies that have been well established for tobacco use treatment and training providers and healthcare workers. And so most of that is easily, and in fact, WHO has a really nice health systems packet with training modules and slides that we actually use. And so the resources, I do think that's actually could be replicated. You know, it may need some translation, and it may need additional, like what we added, what Dr. Nam added was information about the epidemiology of tobacco use in Vietnam, so it became more relevant. And we also like to add to the trainings, you know, the formative work comments from the patients so they kind of understand where patients are coming from. But I do think these trainings are, you know, highly generalizable, honestly, as are these general systems. You know, clinical, we've shown in, again, high-income countries, decision support, performance feedback, some of these chronic care model components are really useful for changing provider behavior, increasing adoption of evidence-based NCD care prevention and control, and cancer prevention and control. And I think it's just taking those things and you know, adapting to whatever the context is. There is still a need for adaptation locally. It's hard to argue that there won't be some need for that. But I think we have growing evidence for, not only we have the evidence for the intervention itself, but we have growing evidence for these strategies, particularly for tobacco control, that I'd like to think are somewhat generalizable. Certainly task shifting is something that countries around the globe are using as a model. And if countries don't have a quit line, which low and middle income countries are less likely to have, they probably have a community health worker program. And we had a very simple 3-session manual that they adopted with fidelity. And these are people who don't have nursing degrees. So I think a lot of those things it does take resources. I'm not gonna, you know, deny that. And motivation from whoever the groups are that are funding this work. What was exciting, I think Nam mentioned, was that we only did a pilot study. So a very small investment from NCI has led to a remarkable outcome, which is, you know, the investment helped Vietnam have now a culturally adapted, translated text messaging system. It only showed short-term efficacy. However, and so it needs continuing monitoring evaluation. We don't want to see that adopted as is without any kind of further assessment. It's clear that you know, patients might benefit from additional resources. They wanted actually to have someone they could text a person and get a response. So there are components that need to be added to that to make it even more effective. So sorry, I went on a little long, Mark, but I'll just add one more thing. There was an NHLBI RFA that came out. I was looking for scale up studies actually. And we didn't get funded, but we proposed a scale up. It was for HIV, so we proposed that. But actually the interest from, and maybe you can speak, the interest from the tobacco program, Dr. Hai, was, you know, why can't we use that money to scale up what you just did? You've shown we can do this in community health centers. Let's go. Let's do it. And so I think there's some support and technical assistance that needs to go into working with policymakers to help that happen. Tobacco fund could fund that, but there's still a need for folks like all of us to support that work. I'm sorry, Nam, did you have anything you want to add to that in terms of scale up?
Yeah, and particularly be interested to hear what you think the prospects are for sort of scaling up the task shifting model and text messaging program in Vietnam.
You're on mute now. Is it talking? No. Oh, there you go.
Yeah. Sorry that my internet was not stable, so I couldn't get Dr. Mark a question. Can you repeat?
Sorry,
that?
yeah, we can hear you now. No, I was just, we were curious about what you think the prospects are for scaling up this program, you know, on a larger scale in Vietnam. You know, both the task shifting model and also the text messaging program. Do you think that policymakers are likely to be open to adopt this, or what else needs to happen before they will?
Yes, Yeah, thanks for the question. Yeah, actually, I also continues with Dr. Shelley's answer the question related to the scaling up adaptation and scaling up. So actually, our first studies we conducted in the community health system, called community health center. That's we have a very strong network of the community health centers at the grassroots level. So actually, from very first beginning of our study years ago, we also collaborated with the Ministry of Health, and we collaborate with them to run the project in the community health system. So, and actually, we provided them evidence, strong evidence that it works. It works in the community healthcare system. And I think that from that time, with the evidence of success in the community health system, the MOH, the Ministry of Health, and the Tobacco Control Fund, they develop their training program. They develop the smoking cessation to the not only the community healthcare system and also to the district level, provincial level, and at the hospital. And actually, we see that we see that adaptation and scale up. And regarding the text messaging, text message systems, smoking cessation system, as Dr. Shelley also mentioned that the MOH is developing the national ISMS smoking cessation system, and they based their system on our ISMS library. That's what we did in the study we mentioned. So yeah, so I think that that will.
Great, thanks. Yeah, so just looking at the other questions in the chat, I see there was a question about which behavioral theory was used for the SMS campaign. And I think Donna already answered that in the chat, that the SMS program was informed by the social cognitive theory and social network theory. Also, another question here, sort of following up on adaptation to other settings. So what about engagement with regional multilateral organizations like ASEAN that may have similar sort of challenges in other countries with high rates of tobacco use? Is there potential to sort of engage with other sort of regional organizations to share the experience you've had in Vietnam?
Yeah, unfortunately, I think COVID has interrupted some of this work, but I think it's a great suggestion. And I do think that that kind of opportunity would be great. We actually had hoped with our original grant, remember? Now, we had hoped to actually do a regional conference, and we ended up not being able to for a whole range of reasons. And so I think that's still an aspiration because we are learning so much. But one of the things we did do was, NAM actually convened with the Ministry of Health a great one-day workshop that included everyone doing tobacco research. We pulled together everyone doing tobacco research in Vietnam. And it was a remarkable day to see, and the Ministry of Health had a chance to be there, the tobacco program, and see what is happening and sort of absorb it and make sense of it as a whole. And sort of think about like where are the gaps in information? What else do we need to do? I think that's really important. I mean, obviously NCI can help and play a role in helping us do that more. That was just in Vietnam, so you can imagine how valuable that would be across Southeast Asian countries.
Yeah. So yeah, so I guess you also, I think you said at the start that the focus, of course, in this project has been particularly on cessation, the offer part of Empower. But I see another question here. Is there a appetite or willingness in Vietnam for stricter laws for regulating tobacco products. So for folks maybe who don't know what the situation is in tobacco control in Vietnam, are there other things happening as well that could help support tobacco control efforts?
Yeah, maybe you can answer that. Yeah.
Yes, and yeah, apart from implementing tobacco succession intervention, the MOH was very willing for stricter laws for regulating tobacco products in Vietnam. And actually, recently we increased the tax for tobaccos, and I think at 2%. And they established the tobacco control fund from the increased tax for the tobacco products in Vietnam. And now with the tobacco control fund, we have a fund to for tobacco control activities in Vietnam.
Yeah. And so I believe that's actually a relatively unique model. I think not many countries have done that.
Yeah, I found that to be, that is it's a strong recommendation from the WHO to do that. I mean, otherwise, how are you funding all this work, you know, coverage for medication, additional monitoring and evaluation systems, and really Vietnam has been a leader in doing exactly what you know the recommendations are, and you know ultimately hopefully we'll see the benefits of that, how that accrues in terms of particularly in terms of our own interests. Our work is making smoking cessation treatment more available.
Right. Well, so we just have a couple of minutes left, but one final question here. So what can NCI do to help support the dissemination of this sort of regional success and continue to support this work?
What do you think, Nam, about, I mean, I guess partnering, you're saying partnering with, right, others, Southeast Asian organizations, and creating a platform for that kind of dialogue. I like the idea of a regional ambassador idea. But yeah, I think it would be, NCI is the one to do it. And that, we could talk more about how that would look. I would love to engage with them. I think, Nam has developed a tremendous leadership role in his own, our own country. And, would be a great ambassador for that. But so would some of our partners there too, the head of the Quit line, Dr. Giap, at Bach Mai Hospital, and Dr. Nguyen, who's been doing all the cost analysis. So I don't know if I can scope out exactly what that would look like. I need like a mural board, but I'd love to engage in that discussion. I don't know, Nam, what I'm not familiar, frankly, with what the Southeast Asian SICTA, there is a tobacco control Southeast Asian organization that we should and could engage with as well.
Yeah. Well, this may be a discussion for another forum, but anyway, we're glad to help and good to.
Yeah, I mean, can I just add one more thing? Because my colleague Martin Raw, who you may know, had developed this approach where he was really, I want to end with just saying, I do think there's a need for technical assistance. Forget about the research hat we all wear, but building capacity like in a place like Vietnam, and partnering with the Institute of Social Medical Science, a group like that with Nam as the lead. We have a lot to offer in terms of technical assistance and real world experience. And so how do you, fund that kind of thing? He had Bloomberg funding for a while that ended, but was really doing some really great work in serving in a sense as an ambassador, disseminating best practices and working to support others to develop those policies and practices themselves. Sorry.
So I see we're at the top of the hour, so unfortunately need to wrap up now, but I think we have some follow-up items to continue discussion on, and encourage folks to continue to follow us, at the Center for Global Health. We do have a series of additional talks planned, including for 2022. So welcome you all to follow us at cancer.gov/global health and on Twitter at NCI Global Health. So thank you, Donna and Nam, for joining us today, and thanks for sharing your work. And thank you, everyone, for attending.
Thank you.
Thank you. Thank you very much.
Bye-bye. Thanks, everyone.